WZTS LD 16 Hinton, Cozy TV.
Doc Talk with Dr. Paul Conley is a production of TTV, which is solely responsible for the content.
Hello, I'm Dr. Paul Conley, the host of Doc Talk. Tonight we're going to be with Dr. Heather Clawges. Dr. Heather Clawges is a sleep specialist who specializes in sleep medicine. There's a whole host of different sleep disorders that she covers, but tonight we're going to be talking about obstructive sleep apnea. And obstructive sleep apnea is something that is severely underdiagnosed throughout the country. There's probably 84 million Americans that have sleep apnea, which that equates to about 32% of the adult population will have some form of obstructive sleep apnea. Dr. Clawges has clinics in Oak Hill, in Lewisburg, but tonight we're here at Brookshire here in Beckley. So Dr. Clawges, thanks for being on the show.
Thanks for having me.
So you were on the show with us years ago, and I really thought I'd like to circle back over here with you again, because I do think that obstructive sleep apnea is so important to talk about. I know that it's something that we talk about in healthcare quite a bit, but then a lot of times I think it gets kind of glanced over or glossed over. But before the broadcast, I was just looking at some of the statistics, and it's remarkable that there's 32%. I mean, it's like 1/3. The U.S. population are going to have some form of obstructive sleep apnea. And so, as I think about that, especially at my age, being over 50, I'm thinking, I myself, very possibly have some form of obstructive sleep apnea. And yes, I know I need to make an appointment. So, if you can, maybe you can talk to us a little bit, what exactly, when we use the word OSA or obstructive sleep apnea, or a lot of people just say the word sleep apnea, what exactly does that mean?
So most commonly, this occurs when you're sleeping. Worse in the supine position, because it's an upper airway obstruction that occurs. So typically the jaw and tongue slides into the back of the airway. So an open airway when we're awake makes no sound, but if the airway starts closing, that creates turbulent airflow and snoring as a result. So snoring is the first sign of an airway that's not functioning properly. If that airway closes enough, then that's sleep apnea. So not enough air gets into the lungs, the oxygen level starts to drop, that sends a distress signal to the brain, and what's the brain do? Briefly wake you up so that it can go back to normal. But the end result of sleep apnea is not getting good, adequate, good quality sleep, because your body's continuously waking you up through the night to breathe.
So I think about, when we talk about, and I know maybe you'll talk about this at some point during the broadcast, we talk about, the stages of sleep and REM sleep. So I think about, your brain's not going to let you, especially as an adult, maybe as a child or an infant, but as an adult, the brain's not going to allow you to basically suffocate. So then the brain only has one thing to do, which is basically wake you up.
Correct. So when we sleep, when we dream, our body becomes paralyzed. So you don't want to be able to act out your dream, right? So if you're dreaming that a bear's chasing you, you don't really want to be able to run and act out your dream. If you lose the ability to have that muscle paralysis, that's a different sleep disorder that I see called REM sleep behavior disorder. But if you lose that, if you have that skeletal muscle paralysis, then it causes more airway obstruction. So sleep apnea is worse when we dream. Dream sleep occurs most commonly in the second half of the night and is important for memory, focus, concentration. So a lot of patients that have sleep apnea don't get adequate amounts of REM sleep, and therefore they have trouble focusing, concentrating, and some data is pointing that untreated sleep apnea can increase risk for dementia.
So I was thinking about, when we were in medical school, right? And I do think that things have changed, or even when you think about in the military, the term Hell Week, and on purpose, intentionally, you would have these, cadets, sleep deprived. And I know, when we were in medical school, you would kind of have a block week or a weekend. And one of the things that you notice is that your cognition, you're foggy, kind of groggy headed. Right. You are impaired. And I can tell you at the end of the week, half of us were sick, from lack of sleep.
Right. Yeah. And so insufficient sleep is part of the symptoms that you see in sleep apnea, but we also know that Americans don't get adequate sleep. 45% of the population does not get an adequate amount of sleep as recommended by the American Academy of Sleep Medicine. So we recommend for adults 7 to 9 hours. So if you're below that 7 to 9 hour marker, you start having symptoms that start looking like sleep apnea. Difficulty focusing and concentrating in kids that present sometimes as ADHD or inability to sit still. So a lot of the consequences that we see in sleep apnea is part of that sleep deprivation that occurs or insufficient sleep.
So 7 to 9 hours. I know that's kind of an average. Is there as we age, does that change from let's say a child, a teenager, young adult, old adult? I mean, do we still require the same amount of sleep?
So actually, adolescents are one of the group that requires even more sleep. So when you're a baby and a toddler, we're looking at between 10 to 16 hours is normal. And then grade school is more like 10 to 13, 12. And then adolescents, you're looking at 9 to 11. And we know that a majority of adolescents don't get that amount of sleep, which is very important for brain development. And then for adults, 7 to 9. Now we know as we age, sleep changes a little bit, and so it becomes a little bit more fragmented. It takes a longer time to fall asleep, but it doesn't change the amount that we need to have positive outcomes on our day. So 7 to 9 is pretty much the recommendation through the rest of the lifespan.
I know we're talking about obstructive sleep apnea, but I do like the fact we're just talking a little bit about sleep hygiene, and I do think that that's probably something else that we can even touch on a little bit, sleep hygiene. So to try to make sure that you're going to try to get that 7 to 9 hours, and I have been to some of your talks where you've talked about going to bed early, going to bed late, timing of going to bed, caffeine in the afternoon. Maybe you can talk a little bit about some of the things that you see when someone says, Dr. Clawges, I just am having a heck of a time even going to sleep. What are some of the things that come to mind that the patient may be doing that's inhibiting them from getting that 7 to 9 hours of sleep?
Yep. So a regularly set bedtime and a bedtime routine that's conducive to sleep is one of the factors that you can implement to greatly affect or benefit your sleep. So to develop a 15 to 30 minute time period to unwind and to do things that are not stimulating, and particularly having an electronic curfew is important because light is the most potent regulator and setter of our daytime circadian rhythm. So the light that's coming from these electronics is telling our brain that it's time to be awake. So having a routine that doesn't involve electronics, artificial lighting is helpful. Anchoring awake time, watching caffeine, that's a big one. I think we have so many energy drinks and the half-life of caffeine is 6 to 8 hours. So what that means is the milligrams of caffeine that you consume, it takes 6 to 8 hours for half the milligrams to be gone. So really the caffeine that you drink in the morning is still around to some degree in the evening. If you're drinking it from 4 to 6 p.m., it's very much still around.
So one thing I think I remember in one of your lectures, you're talking about, going to bed at the same time and not trying to rely on, let's say, quote unquote, sleeping in, because I think you made it about, circadian rhythm, diurnal rhythm, sun comes up at the same time each day. So I think it's, from what you told me, it's easier to go to bed earlier than it is to try to sleep in later. Is that
yes,
still the
so
case?
Anchoring the wake time is very important because even if you didn't sleep well the night before, if you get up the same time in the morning, you'll have a higher degree of sleep pressure. So that circadian rhythm accumulates and you'll be better able to sleep the next night. If you sleep in, you won't have as much sleep pressure and then it becomes just as hard, if not harder, to fall asleep the next night.
So some people, and I want you to kind of talk about this with sleep, trying to go to bed at the same time. And I've heard different people say different things, so I'm going to ask you, you're the expert. Napping, afternoon naps, is that harmful to your sleep cycle? Is that beneficial? If it is helpful, is there a certain amount of napping that's acceptable versus too long, too short? Can you comment on taking naps?
Yeah, so insufficient sleep can cause significant health detriments and can cause trouble focusing, concentrating, etc. You can accumulate a 40-hour sleep debt and pay it back. After that, you can't pay it back. And so when I mean pay it back, I mean by napping. So you can take a nap and it can add back into the total daily requirement that you need. Now, I don't recommend naps if you have insomnia. So if you have trouble sleeping at night, that nap might interfere with your ability to fall asleep. But if you're able to fall asleep, then the nap actually adds to the total volume of sleep you're getting in that day. So naps can be beneficial. Usually we say to limit it at 30 minutes, only because if you sleep longer than 30 minutes, you can go into deep sleep and it's very hard to wake up at a deep sleep. So if you ever had that nap where you feel like you didn't even sleep at all and you feel even worse when you wake up, that's called sleep inertia, and that's because you took your nap too long.
No, I know what you're talking about. It's like now you feel like, boy, I slept too long and now I just feel kind of foggy-headed, and then I don't feel like then I can go to sleep because I took too long of a nap. Yeah, right. I took a nap at 4 o'clock in the afternoon. So also, what about when you talk about electronics and things like that? I have some patients talk about that they have a TV, they watch TV in bed, they do crossword puzzles in bed, they do other things. Is there any certain thing that you would want to talk about as far as television? Is that a good idea, bad idea? TVs, in the bedroom? Bad.
So studies show that if there's a TV in the bedroom, you sleep on average 45 minutes less than people that have no TV in the bedroom. And that can make a big difference in your overall time of sleep. So I say no TV in the bedroom. And what was the other question?
Well, I was just talking about, TVs or other things like doing crossword puzzles or reading a book or doing something other than going to bed or sleeping in the bed. So they use the bed, or the bed is used for other activities than sleep.
Right. So we do recommend not doing other activities in the bed because the brain is smart and it allows you to think. And if you're going to allow it to think in bed, then when you go to sleep, your brain's not as able to turn it off. And so in general, we want to separate and use bed for sleep and other activities outside of the bed. That's mostly for my insomnia patients that we recommend that.
Because I know I have patients that will tell me that, they're trying to catch up on Netflix or some series and they're laying in bed, but then they realize now they're going to sleep at 1 o'clock in the morning and they don't understand why they're so tired all the time, because they got to get up, and then again they're really not able to get that 7 to 9 hours. Now I know we're talking about sleep apnea and we kind of went off topic a little bit, but these are all good things to talk about with sleep. But we are going to get back on to sleep apnea because there's so many things I want you to talk about after the break. I want you to talk about the health consequences of sleep apnea, because it's more than just snoring. It's more than just feeling tired. There's a definite increase of morbidity, mortality, heart attack, and stroke that I want you to talk about. But also I want you to talk about how you diagnose a patient, and of course, most importantly, I want you to talk about how we treat it. So anyway, we're getting ready to come up to a commercial break. I'm here with Dr. Heather Clawges. You're not going to miss. When we come back, we're going to talk about sleep apnea, diagnosis, and treatment. I'm Dr. Paul Conley, so you just stay tuned.
You're watching Doc Talk with Dr. Paul Conley on WZTS 16 Cozy TV. Stay with us. We'll be right back after these messages.
Vandalia Health is proud to be a West Virginia-owned healthcare system, bringing together the hospitals and providers of CAMC, Mon, and Davis. We are dedicated to enhancing the health of our communities through clinical excellence. Our compassion and commitment remain the same with people you know and trust to care for you and your families. With more specialists, hospitals, and outpatient locations, we are delivering expertise and state-of-the-art care. Vandalia Health, expert care close to home.
Welcome back. Doc Talk with Dr. Paul Conley continues on WZTS 16 Cozy TV.
Hello, welcome back to Doc Talk. I'm Dr. Paul Conley, and we are here in Beckley, West Virginia, Brookshire. We are with Dr. Heather Clawges, sleep specialist, and we've been talking about sleep apnea, and then we kind of went and talked a little bit about just sleep, not sleeping, but we are going to circle back around because we're after the commercial break, and we want to talk more about obstructive sleep apnea. And I think, one thing that we talked a bit about the break is about how a lot of people are a little bit afraid to even, be tested for it. I'll do colonoscopies, as that's what I do for a living, I do scopes, right? And so I'll be doing a colonoscopy, and one thing that allows me to do while I'm also, performing the exam, looking for polyps, whatnot, but the patient is being monitored, and I can pick up on that individual, the snoring especially, I'm able to pick up on that. The anesthesia team, they're more picking up on the obstruction that may be occurring with the snoring. And then something that we can talk about a different episode is the restless legs, as I'm getting sometimes kicked as I'm doing the colonoscopy. It's all part of this sleep apnea. So when we think about obstructive sleep apnea, I guess maybe you can talk to us a little bit about what are the risk factors, age, gender, socioeconomics, weight. What in your mind is someone that you say that, if you see someone walking down the street and you say, yeah, I bet that person has sleep apnea, what would clue you in on that?
Okay. So for the pediatric population, because I see kids too, we're thinking big adenoids and tonsils, mouth breathing kids. Very important if your child only mouth breathes at night to have an evaluation, because that can affect lower jaw growth and development, which can affect long-term sleep apnea. The adult risk factors, number one is going to be male greater than female until menopause, and then after menopause, equal incidence. So estrogen protects females. Second risk factor is going to be weight, and that's probably one of the biggest ones. So BMI over 30 puts you at risk. BMI over 35 to 40 puts you in the 70% category of risk. So it jumps from general population stats are 15 to 20 based on what you look at. If you have a BMI over 35, it jumps to 40 to 45% incidence. And then if you have a BMI over 40, we're looking at 75% incidence. So weight highly correlates with sleep apnea.
And I know one thing that when I was in medical school and residency, it's not only just weight, but also, isn't it, neck circumference, men, women? I mean, I know us men typically have bigger necks. Is that also still somewhat of a risk depending on how big your neck is? Like, can you, like me, I can't button up my top button, so that puts me at risk?
So that plays a role. We think there's three factors that play a role. So one is a crowded airway. This is something you're born with. Although excessive weight can add fat to the tongue base, and so that can crowd your airway. But it's why sleep apnea runs in families, so it can be genetic. Secondly, a floppy airway. Some people, the second they fall asleep, everything just collapses. That's what you're seeing with the aid of anesthesia. Some sleep does the same thing. Sometimes stroke, a neuromuscular disorder might predispose you to that problem. And then third is neck circumference. So for females, a neck circumference over 16 inches is a risk factor, and for males, a neck circumference over 17 inches.
Well, that's me. Well, so things that I'd like to talk about as well is the fact we know that some of the symptoms of obstructive sleep apnea are fatigue, tiredness, whatnot, but maybe you can talk a little bit about hypertension, stroke, heart attack. I mean, there's several other things. One thing that I was, on my way over, I was just, looking at a few things sitting in your parking lot, and I was looking at just about car accidents. I was looking at stroke, and I was just talking about all-cause mortality. So maybe you can walk us through that sleep apnea doesn't just equate to just not feeling good and feeling tired, but it actually literally can kill you.
It can. And especially severe sleep apnea. So patients with severe sleep apnea left untreated at 10 to 15 year marker, 55% mortality. Yeah. And that factors out for high blood pressure, for diabetes, for any underlying risk factors that we're looking at. So sleep apnea alone is a very significant risk factor, and it typically is because it can increase atherosclerotic disease, and so it affects the heart. It affects the heart rhythm system, so you can get heart arrhythmias. We know that patients with atrial fibrillation have a 50% incidence of obstructive sleep apnea, and it's very difficult to treat the atrial fibrillation if the sleep apnea is not treated. So these are your patients that have been cardioverted, who take multiple medications. We know that difficult to treat high blood pressure can fall in this category, that you should be screened for sleep apnea. Difficult to treat diabetes, because untreated sleep apnea can cause insulin resistance, increase cortisol levels, which it can antagonize our glucose utilization. I have a lot of patients that once they're on treatment, their medications can go down, so they can decrease their blood pressure medicines, they can decrease their diabetes medicines. So,
one of the things that struck me too is, 50% of folks, adults with hypertension, will have some form of sleep apnea. And you're right, you get a patient who has high blood pressure, pedal edema, the legs swelling, and they're on 2 or 3 different agents, and you're having a heck of a time getting their blood pressure under control. And if they have sleep apnea, they come and see you, they get treated, and then guess what? Their blood pressure is much more manageable. And it's interesting that you talk about the arrhythmias. So I want to throw this out there with my dad. He probably won't care, but he for sure had sleep apnea, and my mother was on him all the time about getting a test. And he's like, no, I'm not going to wear one of those masks, which we're going to get to here in a minute. I'm not going to wear one of those. There's no way I can wear it, et cetera. And I'm sure that a lot of patients, men especially, are bad about being treated. Well, then one day, as she was checking his blood pressure because he had hypertension, she noticed that it was blipping funny, and she said, hey, I want you to check your dad's pulse. Well, I listened to him, and I said, yeah, you're irregular. I suspect you may have sleep apnea. Goes on, gets a 12 lead EKG. He's got AFibs. He's a cardiologist. And the first thing the cardiologist says, because they've become really spot on with you folks in sleep medicine, said, hey, have you ever been tested for sleep apnea? And my mom's like, no. And turns out that he had obstructive sleep apnea. He underwent an ablation, and since the ablation and the usage of his CPAP mask, he's not had any other issues with atrial fibrillation, and his blood pressure is much better controlled. And my mom will say that he's just easier to live with because he's not tired and grumpy all the time.
Right.
And even though he was never going to use that mask, he does not leave home without it, whether it be deer camp, whether it be on a fishing trip, he takes it with him. So I want to get to the treatment because we only have about 5 minutes left before the show's over. So one thing we talked about the break, one thing that you had mentioned to me was that there's a lot of individuals out there that suspect they have sleep apnea, whether because their spouse or someone in the house says, hey, listen, I have to nudge you, I have to push you to wake you up. I'm concerned that that you're not even breathing, but they don't want to go to the test because they have this fear of the test and they have the fear of the treatment. So maybe you can walk us through about how important it is. You talked about the break. You can't diagnose and treat without facts, and facts are your friends. And so if the doctor doesn't have facts, they can't make a diagnosis and treatment. So maybe you can tell us a bit about how you diagnose sleep apnea and how we treat.
Yep, so we have 2 different types of tests. One, it's a little bit more thorough, so it's where you come into the lab. So you come in at 8 o'clock or 9 o'clock at night, you leave at 6 a.m., take your normal nighttime medicines, we hook you up with wires. It gives me movements of sleep, behaviors of sleep, quality of sleep, and breathing of sleep. So pretty comprehensive. And people that are hesitant to do that, or now some insurance companies prefer the at-home, That's another viable method. So basically what we do is we place an order to the lab. You come in the daytime and pick up the equipment. You take it home. You wear it one night at home, and it gives me breathing information only. Now, I do tell patients it's a screening tool, so it's not perfect. So if it comes back negative and we have a high index of suspicion, I will ask for an in-lab, just because not diagnosing and treating sleep apnea can cause so many health issues. We want to be sure, but most of the time the home test does a great job in picking it up. Then moving quickly to treatments, the CPAP machine is the gold standard treatment. That means it treats everyone effectively the best. Insurance covers it. And I tell people, nobody comes into my office asking for the CPAP machine. Like, nobody wants my CPAP machine, but if you give it a month to adjust to, 80% of patients feel like it's life-changing. So I have so many people that although they might be hesitant to try treatment at first, once they try it, they get a comfortable mask, they realize how well they're sleeping, how good they feel in the daytime, then they're willing to accept it, and it works well. Now, for those that don't want to do the CPAP, we have other options. So oral appliance is a device that's made by a dentist that holds the jaw and tongue slightly forward while you're sleeping. It's a good device for mild to slightly moderate sleep apnea. We have surgical interventions that are guided by ENT, so they can do staged approaches to help relieve different levels of obstruction. Or the new Inspire device, which is like a pacemaker for the tongue. So it stimulates the tongue and pushes it out of the upper airway. Lastly, we have Zepbound, which was recently approved. It's a GLP-1 GIP shot medication that's given once a week, and it helps facilitate weight loss. And in return, 1-year studies have shown that there's a 50% reduction in obstructive sleep apnea. Sometimes we use that in combination with PAP, the Zepbound, and in some patients we just use Zepbound. So, lots of options.
So with the CPAP, that being, sounds like, the gold standard, how does the patient, do they come back and see you? How do they know the titration? How do the masks work? I know things have changed now. They have auto titrating masks, and maybe we got 2 minutes left to go. You can talk to us a little bit about the mask and the availability of the mask and how the masks fit, and then how, again, if someone were to lose that amount of weight, do they need to come back and see you and even have the mask adjusted? Or if they unfortunately gain weight, when should someone come and see you and have the mask refitted?
So we follow all of our patients if they're having trouble once a month, but if they're settled in and doing well, every 6 months to even a year, just to check in, because circumstances happen, life happens. We have 20 different masks on the market. Masks are so important. So we see patients back after that study, explain what the severity of their apnea is, what the treatment options are, and then if they opt for CPAP, then we figure out what mask works best, what pressure works best. We can do that 2 ways. One is coming into the lab, a little bit more formal. Again, you sleep all night. Or we can do an auto-titrating machine, a smart machine, and then mask fitting as an outpatient. So either way, I try to accommodate my patients. We have to listen to insurance, but I try to help the process be as positive as possible. Yes, weight can change pressure setting requirements, weight can change mask requirements, and it can also eliminate sleep apnea. So if you lose enough weight, we repeat the study and see if you still need treatment. So we follow our patients long term, essentially.
Well, good, because I think that's one of the things that people, get on a mask, but that doesn't necessarily mean that that's going to be the same mask you use. And again, when I was in residency, I don't think we had 20 plus masks. There was not, this auto titration and all the different things that are available now. And again, CPAP stands for continuous positive airway pressure, and basically just putting pressure, opening up the airway so you don't obstruct.
Correct. Yeah, and I tell patients, just because you failed years ago doesn't mean that you're going to fail now. Let's retry it. Yep,
and people that passed years ago have gained weight, then maybe they need to circle back around. But Dr. Clawges, I really appreciate you here. Dr. Clawges is our sleep specialist. She's here at Brookshire. She's also in Lewisburg and Oak Hill. I'm Dr. Paul Conley. We've been talking about sleep apnea. Until next time, have a good night.
WZTS 16 Hinton Cozy TV is your local television station, serving southern and central West Virginia with classic shows and original local programming. Whether you're watching comfy classics you know and love, or content created right here by local voices, WZTS delivers programming you can rely on every day. Learn more about our station, programming, and coverage areas at WZTS.tv.